All right, doctor. So now we are live. So now you can please start your session, sir. Over to you, sir.
Hello, good evening, everybody, and welcome to today's session on lactic acidosis. So, thank you, Sipla, for being our academic partner and help me to prepare the platform.
Sir, sorry for the interruption, but your video is just off, sir. If you want, you can just make it on.
Yes, yes. Now it's correct.
Yeah, perfect, sir. Please start, sir.
Okay. So, we all know that lactic acidosis or at least hyperlactatemia is a very common finding in ICU. But out of every three patients, probably will get one patient with a high lactate. And now the challenge is to decide whether to intervene or whether we should just monitor. We will come across different etiology that can cause lactic acidosis or hyperlactatemia in ICU. And some of them need intervention, some of them is a part of the inflammatory process that's happening in the background in the patient. So probably they just need monitoring and intervention or treatment of the primary problem rather than addressing lactic acidosis per se. So myself, Dr. Sudipta, I'm working in the as a critical care consultant in Tata Medical Center company. So if you look at the history of lactate, how it was first identified. So initially it was measured in human blood. It was first described by Scherer in 1843. He described a lethal case of fulminant septic shock due to puerperal fever in a young woman who found to have a very high lactate. Now, after that, in 1964, after nearly 120 years later, Broder and Weil first used lactate as a clinical prognostic tool. That we presently all are aware that if lactate is high and it is not getting lower or getting cleared, the patient's outcome is poor. He also described that lactate excess of 4 millimole per liter was associated with a poor outcome in patients with undifferentiated shock. In this situation, lactate level was described or considered as a severity of the underlying disease. Surviving sepsis guideline, when it was started in 2002 until 2021, they always give priority to lactate and more precisely to lactate clearance. Even in the recent guideline, in the first initial resuscitation of the 1 hour to 3 hour, they have recommended to measure lactate, continue with our initial resuscitation, and eventually follow lactate to look for clearance. So we have to understand the physiology behind the lactate production and its metabolism. It is mostly produced by most of the organs in the body. Highest level of production happens in the muscle. It is primarily done by high glycolytic tissues, which has LDH-A type of LDH, lactate dehydrogenase. So LDH means lactate dehydrogenase. A type is present or required for production, and it is enriched in skeletal muscle. And approximately 20 millimole of lactate per kilogram of body weight is produced in a day. Under normal condition, it is rapidly cleared by the liver, which is the main organ for lactate clearance, and to some extent it is done by the kidney. This lactate is reconverted to pyruvate and consumed in the mitochondria in tissues where lactate dehydrogenase B type is present. In anaerobic condition in our body, we usually produce acetyl-CoA that enters the tricyclic acid cycle or Krebs cycle, undergo oxidative phosphorylation in the liver, kidney, muscle, heart, brain, and other tissue, which eventually generate ATP, carbon dioxide, and water. But what happens in anaerobic condition? It can be relative, it can be absolute. There is a production of lactate because Krebs cycle become a rate limiting step. Acetyl-CoA could not enter. And as a result, lactate is produced as an end product of glycolysis. In terms of its metabolism, it enters Cody cycle as a substrate for gluconeogenesis, generates glucose, but it consumes ATP in the liver and kidney. So glucose is generated at the expense of ATP consumption. What happens at tissue level? At tissue level, there are intra-organ and inter-organ lactate shuttles. It is usually facilitated by monocarboxylic acid transporter, and it usually leads to influx and efflux of lactate and accompanying protons in the tissue. The bioenergetic equation for lactate generation is glucose plus 2 ATP and inorganic phosphate equal to 2 lactate plus hydrogen and ATP. And its production increased whenever this pathway is exaggerated, are expressed more, like in exercise, seizure, or in exogenous, whenever there is a excess exogenous load that can happen because of the containing fluid. In terms of production, it is pyruvate plus NADH that produce lactate and NAD. Pyruvate is generated mostly by the anaerobic glycolysis in the membrane pair of pathway. The redox-coupled interconversion of pyruvate and lactate mostly happens in the cytosol of the cell, contrary to the Krebs cycle that happens in the mitochondria. Here it is catalyzed by lactate dehydrogenase, which is a tetramer of 5 isoform, each made up of different combination of two subunits, lactate LDHA and LDHB. And we already mentioned that LDHA helped in production of lactate and LDHB is more contributing to metabolism of lactate. The nature of LDH isoform in the tissue does affect the lactate metabolism. Normal blood lactate pyruvate ratio is usually 10:1, and it raises with an increased ratio of NADH to NAD during a certain redox situation. So we need to understand the equation I have mentioned, that pyruvate plus NADH plus H equal to lactate plus NAD plus H2. This is basically a bidirectional equation. So if one concentration goes up, it can move in the opposite direction. And this is how lactate get metabolized. Around 2% of the lactate is excreted unchanged in the urine and mostly converted back to pyruvate, we have discussed. Now this pyruvate may enter the mitochondria and conversion to acetyl-CoA and subsequent metabolism to citric acid. Otherwise, they convert it to oxaloacetate and ultimately glucose. This occurs only in liver and kidney. If you look at the lactate subtype, it has two. One is L-lactate and D-lactate. What is more clinically relevant is L-lactate. That only we can measure in our clinical practice, and it is the primary isomer produced in human. D-lactate, on the contrary, can be produced by bacteria in human colon on exposure to large amount of unabsorbed carbohydrate. Alteration in intestinal flora and a high carbohydrate dose, sometimes something like short bowel syndrome, can produce excess D-lactate, and it can cause the bloodstream. And it has potential to cause neurological symptoms. But in present mechanism, we cannot measure it. Now, if you look at the pathophysiology of lactate production, which is clinically relevant, most important is tissue hypoxia. It can be global or localized. We already discussed eventually in tissue hypoxia, the acetyl-CoA cannot be metabolized or cannot enter into the Krebs cycle and eventually produce lactate. Now, this lactate overproduction can be associated with underutilization as a result of impaired mitochondrial oxidation. Now, and that can be also because of microcirculatory dysfunction, because of regional tissue hypoxia leading to hyperlactatemia. Microcirculatory dysfunction and impaired mitochondrial oxidation is two important pathophysiological parameter of sepsis. As a result, there may be increase of optimal oxygen delivery to the tissue, but because of these pathophysiological changes, tissue cannot utilize this oxygen. And as a result, in this type of patient, you will get a high lactate along with a very high SCVO2. It indicates a poor prognosis, that even when the oxygen is present, tissue is not in a situation to utilize it. There can be associated coexisting acidemia because of decreased lactate removal by the liver. In severe hypoxia and acidemia, can convert liver into a net producing organ rather than lactate metabolizing organ. This is Surviving Sepsis Guideline 2021, and we all are very, very aware of it. That is a strong recommend that you should measure lactate and followed by monitor lactate and guide our resuscitation on its behalf. But if you look at the evidence is mostly low, very low, and best practice about the initial resuscitation. It is mostly conceptual rather than evidence-based. So, whenever we are applying this information or numbers, we need to utilize our clinical knowledge also. So, what is our target at the initial resuscitation? It is to increase oxygen delivery to the tissue or decrease oxygen demand at the tissue level. So, we administer fluid, we administer inotrope, that is increase the contractility and increase cardiac output, give blood transfusion as an increase oxygen carrying capacity, give mechanical ventilation and paralytic agents, sedative and analgesia, just to reduce oxygen utilization at the tissue level, mostly in the skeletal muscle level, including diaphragm. Now, if you look at the clinical practice, as I mentioned, lactate as a resuscitation endpoint also has been used in trauma scenario, and there is no evidence which suggests that it improves survival. So we have to use it judiciously at a physiological endpoint rather than a clinical endpoint. International Consensus Conference on Hemodynamic Monitoring and Management in 2006 has mentioned that there is a lack in clinical trial that investigate the clinical value of incorporating lactate is a treatment protocol because it's a costly affair. Now, what about aerobic glycolysis? Here in aerobic glycolysis, there is a situation called stimulated glycolysis. And because the aerobic glycolysis is activated in response to stress. It is a classical example in sepsis in the initial period when there is a severe inflammation going on. As a result, there is an effective but inefficient mechanism of rapid generation of ATP. The entry of acetyl-CoA into the Krebs cycle is a rate limiting step. So one is a large number of acetyl-CoA, every molecule cannot enter to the Krebs cycle. As a result, to increase the production of enzymes, you have to bypass that. And as I mentioned, the best example is hyperdynamic stage of sepsis. There is an epinephrine-dependent stimulation of the beta-2 adrenoceptor, which is also augment glycolytic flux. As a result, both directly and through enhancement of the sarcolemmal sodium potassium ATPase, which consumes large quantity of ATP, anaerobic glycolysis process and lactate production increases. Also, there are disorders which are associated with elevated epinephrine level, which cause this increased lactate production, like in severe asthma because of overuse of beta-2 adrenergic agonists, extensive trauma, cardiogenic or hemorrhagic shock, pheochromocytoma, cytokine-dependent stimulation of cellular glucose uptake, and in alkalemic situation also because of stimulation of 6-phosphofructokinase. There are drugs which can cause lactatemia. One is obviously mentioned the sympathomimetic or adrenergic drugs like salbutamol or adrenaline. Some drugs which impaired oxidative phosphorylation like antiretroviral agents and propofol. And we all aware of the metformin which can cause lactic acidosis. The whole group of biguanides can cause lactic acidosis, and mostly it is clinically significant in the background of renal dysfunction. Except metformin, all the other biguanides has been withdrawn from the market because of this complication. Now, what about liver? Liver is usually the organ which metabolizes lactate, and 70% of the whole body's lactate is cleared by the liver. In patients with sepsis, who is hemodynamically stable and have normal liver function, lactate clearance, even in this situation, can be reduced by liver through inhibition of pyruvate dehydrogenase. And chronic liver disease, usually this type of hyperlactatemia exacerbates. And even then clinically relevant lactate increase is always minimum, even in severe cirrhosis. But in acute condition, that is acute fulminant liver failure, hyperlactatemia can be very common. It reflects both reduced clearance and also, as I mentioned, there is increased production of lactate by the liver, and it indicates a very important prognostic factor. It indicates a poor prognosis. What about cellular dysfunction? We all discussed that eventually the acetyl-CoA is metabolized at the cellular level. It enters the mitochondria and gets metabolized. Now, if there is a tissue hypoxia with mitochondrial dysfunction, or there is a severe acidotic milieu at the cellular level, as a result, there can be decreased metabolism and increased production of lactate. That's why whenever there is a severe acidosis, even whatever is the cause, the pH is less than 7.1 or in DK 6.9, we usually give some sodibicum just with an attempt to improve the cellular pH, so that all the enzyme dependent mechanism that had working at the cellular level is get restored and the pathophysiology may get reversed. So it can decrease this because of the cellular level of acidosis. It can decrease cardiac contractility, cardiac output, blood pressure, and tissue perfusion. It can sensitize the myocardium, leading to cardiac arrhythmias and can attenuate cardiovascular responsiveness to catecholamine. We found there are times when the shock is refractory and not responding neither to noradrenaline or adrenaline. That is because of severe acidosis. And we usually give some bicarbonate irrespective of the mechanism. And it basically makes a vicious cycle. So severe acidosis, poor cardiac contractility and blood pressure, worsening acidosis, and the vice versa. And severity of the acidosis was a better predictor of cellular dysfunction and clinical outcome rather than lactatemia alone. And what is the effect of lactatemia on direct effect of lactatemia on cellular function? It is unclear. And lactate that can cause decrease cardiac contractility. It is basically a soft data. It may be because of lactate or maybe because of the acidosis that has been created at the cellular level. Now, in terms of classification, lactic acidosis or lactatemia can be because of tissue hypoxia, which is called type A lactic acidosis, when usually because of cardiogenic or hypovolemic shock, heart failure, severe trauma, and in sepsis. And in type B lactic acidosis, where there is no tissue hypoxia, mostly either it is because of drug-induced or because of increased cellular turnover, in case of severe cell breakdown, or maybe because of decreased metabolism. How to diagnose? It have to be interpreted in an appropriate clinical condition. If one line you want to remember from the whole presentation, this is the line that it have to interpret in appropriate clinical condition. Day 4 of ICU stay, lactate jump from 2 to 4. It does not indicate patient is hypovolemic. Don't jump to give 2 liter fluid to this type of patients. It have to have a high index of suspicion, specifically in the background of elevated serum anion gap and high osmolar gap. If your ABG machine is not measuring lactate routinely, there are machines which does not measure lactate routinely, and you have to send the blood for lactate in the lab. So if someone has a high serum anion gap with high osmolar gap, you have to consider lactic acidosis. Though lactic acidosis can happen in normal anion gap also, and nearly 50% of the cases of serum with a lactate level 5 to 10 that is on elevated anion gap, and rest 50 it is normal. If you look at the gap junction, that is delta anion gap with delta bicarbonate, if it is more than 1, there is an apparent space of distribution of proton that exceeds that of lactate. So we have to consider associated other cause of metabolic acidosis. So normally the upper limit of normal for lactate is 1 to 2.2. Most studies take cutoff as either 2 to 2.5, and when we talk about high lactate, we usually make it 4. Even lactate on the upper tier of the normal value is indicated poor prognosis, and it shows to increase mortality in critically ill patients. And eventually, if there is a high lactate with acidosis, that is pH less than 7.35 or a serum bicarb less than 20, then we can call lactic acidosis. Otherwise, it is lactatemia. If we look at the metabolism, there is no clinically important relationship between lactate and pH and base excess. As I already mentioned, patient can have a high lactate with normal pH. During lactate was only responsible for minor percentage of metabolic acidosis in critically ill patients. Because when you look from conversion to pyruvate to lactate, it does not directly result in production of hydrogen ion. Only if the hydrogen ion is generated during hydrolysis of adenosine triphosphate. That cannot be recycled in the mitochondria. That is in anaerobic condition. Only then acidosis will coincide with hyperlactatemia. And there is an increased lactate level can lead to strong anion difference. And as a result, there is an acidifying effect. This is basically called Stewart approach of reviewing or assessing acidosis, where the understanding is there is a strong anion gap which is around 40. If the anion gap decreases, there is acidosis. If the anion gap increases, there will be alkalosis. Measurement, mostly it is done in as a point of care in the new modern ABG machines. There is a satisfactory agreement comparing the capillary, venous, central venous, mixed venous, and the arterial level of reference of lactate. So if we want to monitor lactate level, an ABG or a VBG suits well, both suits well. Few describe the slightly higher peripheral venous or capillary level of lactate, but it is not clinically significant. If the ongoing in vitro glycolysis after the blood sample is happening or continuing, there can be erroneous elevation of lactate. That can happen in leukocytosis or if the patient is a very high hematocrit. Leukocytosis means with a WBC count more than 1 lakh or 1.5 lakh. That happens in AML with blast crisis or in CML. See AML or CML with blast crisis. So in that situation, analysis have to be done as early as possible, preferably within 15 minutes, or you have to store the blood sample at 4 degrees. What are the other erroneous factors that can influence? Is the infusion of the ringal lactate. Theoretically, has lactate, so it can have increase the lactate level, but it does not increase. There is a very small chance. It does not hamper accuracy of blood lactate measurement. Most commonly used critical care drugs does not affect the accuracy. Renal replacement therapy can eliminate only a small amount of lactate. So if you want to replace lactate, remove lactate, dialysis is not an option unless you are doing a hemodiafiltration which can remove the small molecule. At the same time, as I already mentioned, lactate is a surrogate marker of something wrong happening at the tissue level. It is not a toxic molecule that you need to remove. Another thing that can influence is the lactate containing buffer solution. How to work up? It have to be patient specific and the disease specific. So this lactate elevation can be because of increased production, decreased clearance, or both. In shock state, the contributing factors are hypoperfusion due to macro or microcirculatory dysfunction. We can address the macrocirculatory dysfunction by optimizing our hemodynamics, but we cannot address microcirculatory dysfunction. That can be changed only the primary process. Primary inflammatory states start reversing. There can be mitochondrial dysfunction, including potential lack of key enzyme as cofactor, like thiamine or other enzymes, and presence of hypermetabolic states that you cannot do. You have to sit tight, give your organs support, and wait and watch. In liver dysfunction, there is increased production, decreased clearance, and it has become more important in case of hypoperfusion and in shock stage. Along with this, in case of grand mal season, there can be hyperlactatemia along with normokalemia, because there is a concurrent entry of lactate and protein into the cell that negates the need for potassium exit from the cell. So you will not get a hyperkalemia, contrary to situations when there is a cell lysis leading to hyperkalemia and high lactate. And there is a good NEJM paper which lists out all the causes of lactic acidosis along with the presumed mechanism. So it is basically, as this part I have discussed already, decreased oxygen delivery, stimulated by epinephrine-induced beta-energetic stimulus, increased oxygen consumption or increased requirement. Or in cancer, there is a funny thing happens, which is called, there is an increased glycolytic activity of the tumor, which is called Warburg effect. These cancer cells are dependent on the glycolytic pathway only, leading to more production of acetyl-CoA and eventually lactate. So what is the treatment? Treatment is addressing the primary problem and focusing on the macro circulation. That is the primary concern. So we try to increase oxygen delivery to the tissue. We optimize cardiac output. We try to optimize regional blood flow, hemoglobin concentration, and at the end, partial pressure of oxygen. We all know the contribution of partial pressure of oxygen while carrying oxygen to the tissue or as a component of total oxygen carrying capacity of the blood is very, very minimum. So measures the target, and we have to intervene the cause or the causes of lactic acidosis. Intravenous sodium bicarbonate in case of severe acidosis. Some use 7.2 as a cutoff pH. You can go beyond 7.1 if there is no significant hemodynamic instability. But there is a very limited role in reducing mortality or improving hemodynamics because by giving sodium bicarbonate. What are the adverse effects? That's why I will strongly recommend not to use sodium bicarbonate unless you are really desperate. It causes intracellular acidification due to the accumulation of carbon dioxide after bicarbonate infusion. So basically, contrary to our belief that we are improving pH, we are basically decreasing pH at the place where it matters most. Along with that, there is a pH-dependent decrease in the level of ionized calcium, which is a modulator for cardiac contractility. On the other hand, hemodialysis can be a better option to provide bicarbonate because it can prevent a decrease in the ionized calcium. It prevents volume overload and hyperosmolarity, potential complication of bicarbonate infusion, and it removes the substance associated with lactic acidosis such as metformin, though this is little theoretical. An alkalizing effect with base administration eventually lead to net lactic acid production because bicarbonate will eventually metabolize to produce lactate. There are other options like THAM and carbicarbon. There are some small data, but these are presently out of practice. So what is our target basically? We need to optimize the microcirculation by addressing the macrocirculation, provide maximum oxygen carrying capacity by optimizing hemoglobin concentration and oxygen saturation, optimize acid-base status, try to improve the lactate clearance by all this, and assess the integrity of the microcirculation. Try to address it by addressing the primary pathophysiological problem. Like in sepsis, the primary problem is infection, so we try to give optimal antibiotic. So what are the future therapies? So these are two interesting future therapy. One is to use sodium hydrogen exchanger. It usually activated during lactic acidosis, and it has a deleterious effect on sodium and calcium overload in the heart. So if you use sodium hydrogen exchanger inhibitor, it attenuates the lactic acidosis and hypotension, improve myocardial performance, and tissue oxygen delivery, enables resuscitation and reduce mortality. And this is absolutely at the research level. Second one is more interesting. We have already discussed cancer cells are programmed to use, some cancer cells are programmed to use anaerobic glycolysis and lactate production as their main energy source, which is called Warburg effect. So if we can inhibit the LDH and MCT lactate transporter, it can be a critical regulator in cancer development, maintenance, and metastasis by regulating export of lactate and protons in the tumor microenvironment. These are under research. Now, as we already discussed regarding the lactate as a resuscitation endpoint, this is another paper which compared lactate with targeting peripheral perfusion status by the capillary refilling. This is called Argomeda shock trial. So, if the lactate facility is not there, then this practice can be accepted, and it compared normalizing capillary refill time by normalizing or decreasing lactate clearance at a rate greater than 20% for the first 2 hours during an 8-hour resuscitation period. And they found that by the end day 28, around 35% of the peripheral perfusion group and 43% of the lactate group has died. That means eventually there is no statistically significant. Both are good in predicting mortality. But peripheral perfusion target resuscitation was associated with a lesser organ dysfunction at 72 hours, and they require less amount of resuscitation fluid compared to lactate. Because as I mentioned, lactate along with peripheral tissue perfusion, it indicates a lot of other underlying pathophysiology, which is not going to reverse with excess fluid. Does it have a diagnostic role in sepsis? It is not a direct role, but it indicates that with high lactate or elevated lactate, there is an increased chance of mortality on patients, irrespective of the shock. We all know that even if the patient has a normal blood pressure, if the patient has a high lactate, we consider it as a shock as per surveying sepsis guidelines. These are called occult or cryptic shock, and these need to be addressed. More important role of lactate as a prognostic marker. Its absolute value and also the value of the lactate clearance. So hyperlactatemia does not always signify tissue hypoxia. Sustained hyperlactatemia in hospitalized patient, it indicates a poor prognosis and large increase in mortality, regardless of the status of the shock or hypotension. Even a single elevated blood lactate value indicate adverse outcome. And there is a dose-dependent response relationship between lactate level and mortality. So the higher the lactate level, greater risk of mortality, irrespective of the primary pathophysiology. Patient who can clear an initially elevated lactate within 24 hours usually significantly had a better outcome, because it indicates not only the macrocirculatory perfusion is good, patient has started reversing the underlying pathophysiology. So it is beyond circulation. It indicates that the underlying pathophysiology is also getting reversed. So obviously these patients are expected to have a better outcome. Serial lecture measurements can be useful guide to document treatment response. Now regarding oxygen guided lactate guided oxygen delivery. So if we have a protocolized way to deliver or increase oxygen delivery according to the lactate, it shows that lactate level decreases significantly during lactate guided therapy. It coincides with increase in SCVO2, and patients who respond to normalization of lactate has a lower mortality than those who remain hyperlactated. But again, I'm mentioning you have to utilize it in appropriate clinical scenario. This is more applicable when the patient has a sepsis along with poor LV systolic function, and you start low SCVO2 to begin with. Then you optimize your hemodynamics, improve tissue oxygen delivery, increase SCVO2, and there is a decrease in the lactate. Because if lactate is contributing as a part of other pathophysiology, this mechanism is not going to work. Still, there are studies which show if you go by a lactate guided therapy, there are junior intensivists who are managing the ICU, non-intensivists who are managing the ICU. If you go by certain protocols or structured way that they have developed, probably they are going to have a better outcome rather than just by clinical assessment. So this is another study which shows that lactate level is not only at the clinical outcome, but with early lactate clearance, there is a change at the tissue level also in terms of inflammatory markers, coagulation parameters, apoptosis, and eventually it improves organ dysfunction and mortality. So what they have done, they look at the arterial lactate along with different biomarkers which will indicate the inflammation at the tissue level, like interleukin-1 receptor antagonist, interleukin 6, 8, 10, TNF alpha, intracellular adhesion molecule, high mobility molecule, DEPOX1, D-dimer, caspase. Along with they monitor the organ function like acute physiology and Apache score 2, simplified acute physiologic score 2, multi-organ dysfunction score, and SOFA score. And they found that the mean level of all biomarkers and organ dysfunction score over 72 hours were significantly lower with high lactate clearance. There is a significant decrease in hospital mortality, 28-day and 60-day mortality in patients who has a higher lactate clearance. And high lactate clearance as a surrogate for resolution of global tissue hypoxia, specifically when there is a macrocirculatory dysfunction. What about cardiogenic shock, obstructive shock? It has not been evaluated extensively, but if you understand the underlying pathophysiology, that patients with a myocardial dysfunction resulting in shock after cardiac surgery, they show profoundly high elevated lactate because of poor cardiac output and poor tissue perfusion. It related to increased tissue and leading to increased tissue lactate production. Patients with cardiogenic shock who require extracorporeal membrane oxygenator, lactate has been found to use as a parameter for predicting mortality. That because once they are an extracorporeal membrane oxygenator, lactate rather than perfusion, along with perfusion, it will also indicate what happening at the tissue level. In patients with cardiogenic shock following ST elevated myocardial infarction, patients with ineffective lactate clearance, that is lactate clearance less than 10, indicate a lower survival. So even in a cardiogenic shock, they show a poor outcome as a part of prognostic rules. Even in pulmonary embolism, the patient has a high lactate. It is associated with increased mortality, independent of hemodynamic status and right ventricular dysfunction. What about trauma? Lactate levels are significantly elevated both in traumatic and non-traumatic hemorrhagic shock as compared to the control. But in traumatic shock, it has a higher value because the associated inflammation is also there. Mostly it is because of hypoperfusion, most often related to the blood loss. And sometimes it helps us to pick up occult hypoperfusion. That is, patient's blood pressure is maintained, but there is a poor tissue perfusion. Mostly happens in young patients who have a good reserve. Elevated lactate may help to identify a patient whose initial normal vital signs may mask ongoing tissue hypoperfusion. That can happen in trauma because of severe pain, young patient with a good cardiac reserve. So initial lactate level has been found to be significantly higher in non-survivor compared to survivor in trauma. That means again, it has a prognostic role. The degree of elevated lactate and the rate of lactate clearance strongly correlate with risk of multi-organ dysfunction and survival following trauma. So again, along with absolute value, the clearance has a good prognostic role in traumatic scenario. Lactate clearance could potentially serve as an endpoint to guide resuscitation. In post-cardiac arrest scenario, again, what are the etiologies for persistently elevated lactate? This is a very common finding in post-cardiac arrest patients. We have to understand this is not hypovolemia. It's because of systemic inflammatory response and ongoing tissue hypoxia, myocardial staining causing cardiogenic shock, and uncorrected underlying etiology that lead to the arrest, that will be the cause of the hyperlactatemia, microcirculatory dysfunction, and mitochondrial injury and dysfunction. Last two is very, very important. This happens because of perfusion injury. During arrest, there is a poor perfusion. When there is an ROSC, there is an improved perfusion. It leads to microcirculatory dysfunction because of mitochondrial injury and dysfunction and inflammation at the cellular level. Now, once we combine initial lactate value and the need for vasopressor support in the immediate post-cardiac arrest patients, we stratify patients' prognosis and accurately predict outcome. So, if initial lactate is less than 5 and no vasopressor, mortality is around 40%. Initial lactate more than 10 and recurring vasopressor, mortality can be as high as 90%. And we can very much find it in our regular practice. So the ability to clear lactate in the post-cardiac arrest period is also a predictor of increased survival. That means that patient's underlying pathophysiology is getting reversed. And along with that, lactate can be high because of excessive muscle activity. One of the examples is seizure, that is profound elevated lactate, but it is mostly transient. Lactate level increase also with heavy exercise because of anaerobic metabolism. In acute severe asthma, lactate increases in the first 6 hours after admission due to either excessive muscle work because of the diaphragm and the respiratory muscle or are actively moving, also because of beta agonist. But there is no association with mortality or progression of the respiratory failure. Sometimes in ICU patients, use of restraint in a delirious patient or intoxicated patients lead to increased muscle activity and can lead to and tissue hypoxia lead to high lactate. In regional ischemia, again it can lead to hyperlactatemia, and early lactate can be a marker of early recognition of eccentric ischemia. And studies in animal model have shown the lactate start going up within 1 hour of induced bowel ischemia. But if you look at the sensitivity, it is very high, 96%, but specificity is very poor. So it can be because of other reason also. But it indicates that there is an increased mortality with the high lactate level. What are the other causes of acute abdomen that lead to hyperlactatemia? It can be because of bacterial peritonitis or acute pancreatitis, acute lower extremity compartment syndrome, pathophysiology same, poor perfusion, and also in Fournier gangrene and other type of necrotizing soft tissue inflammation, infection because of severe infection and tissue destruction. So to conclude, lactic acidosis and lactatemia is a very routine clinical finding in our practice. Most of the ICUs have ABG machines, and if we are looking at the lactate value, we sometimes will get more than 2 and sometimes more than 2. 2 to 4 is the high, but not that clinically significant, but studies shown that even that has a poor outcome. High lactate does not mean macrocirculatory dysfunction or macrocirculatory hypoperfusion. We have to review for macrocirculatory hypoperfusion where there may be other causes. At the same time, we have to address for the other causes of lactatemia, like starting with just systemic inflammation, along with lack of important coenzymes like thiamine. So even in hyperlactatemia can happen because of thiamine deficiency and need to be replaced. By this, I'd like to conclude my presentation and will be happy to take answer. Thank you for your patience. So if anyone want to ask any question, you can please unmute yourself and you can ask.
Yeah, thank you so much, doctor, for that much informative and elaborate presentation, sir. So I request to the attendees, if you have any questions, you can just write down in the chat box. Doctor, we can just wait for the next 1 minute.
Sure.
Well, sir, I think there is no questions, and every attendee is just sending regards to you. Like it's a great presentation. So, any parting comments, sir?
Thank you everybody for the present listening. And it is a very important topic to understand. Once you understand, have a patient with a high lactate, try to understand the underlying pathophysiology rather than take it on its face value as a tissue hypoperfusion. Because survival services guidelines promote lactate hyperlactatemia as a indicator of hypovolemia and hypoperfusion. It is there, but there are other causes also, specifically after the initial resuscitation of 3 to 6 hours. So after 6 hours, persistent hyperlactatemia should not indicate a tissue hypoperfusion. The component of tissue hypoperfusion should be taken care within first 1 to 3 hours. After that, we should look for other causes. Some need intervention, some need direct intervention for the hyperlactatemia, some need intervention for the primary problem. which is causing the hyperlactatemia. And thiamine deficiency can be a very important factor. Don't if there's a persistent hyperlactatemia, please replace thiamine. And again, thank you for joining us.
All right. Thank you so much, sir.
Thank you, everybody. Have a nice day.